So this is a humongous topic, and way more than can be completely covered in 15 minutes. So I just picked a few aspects of cannabis use and chronic pain, and I tried to highlight some studies that were published actually in the last year or so, because maybe some of you may be familiar with some older ones, but some of the newest stuff that's come out you may or may not be familiar with. So next slide, please. So this is the accreditation statement, conflict of interest. I served on an advisory board once for a novel pain treatment from Sorrento Therapeutics in 2016. So overview. We'll briefly talk about the various cannabis compounds used for the relief of chronic pain, talk a little bit about a study that looked at motivations for cannabis use, including chronic pain, discuss the evidence from a different study for medical marijuana and improvement of chronic pain, talk about CBD compounds and see whether they help chronic pain or not. And then there's kind of a growing topic of research is substitution, whether people are using medical cannabis to substitute for other medications instead of opioid medications, benzodiazepines, and other such medications of interest. Next slide, please. So overall, there's various different cannabis compounds used for chronic pain. There's even more than are on this slide, but these are some of the major ones. So there's marijuana, either medically or recreationally. People obtain it. Medical marijuana now is legal in 33 states and Washington, D.C., although technically, as we all know, it's still illegal under federal law. Recreational marijuana is legal in 10 states currently. CBD oil is typically legal if it's 0 or low dose THC compounds, so less than 0.3% THC, and they're primarily hemp-based. There's some other compounds. There's Sativex or nabiximols, which is an oral mucosal cannabinoid spray that you can use. And it's approved in Canada and Europe so far. It's not approved here yet. Interestingly, that actually has a 1-to-1 ratio of THC to CBD, so it actually does deliver a fair amount of THC per spray, and there's a maximum of 12 sprays a day. And its indication is primarily for multiple sclerosis-related spasticity and pain. There's also a few different synthetic cannabinoids in development right now that are not ready for prime time, obviously. So there's just a couple of things in the pipeline. So pain relief is a motivation for cannabis use. There's a lot of concern about adverse effects. If you use cannabis really early, there's some suggestion that repeated exposure might lead to greater risk for tolerance, greater risk for dependence, more problems both in their life and socially and with use disorders, things like that. There's one thing they showed was 21% of 18 to 25-year-olds in the US endorsed use in the past month alone, so pretty high. This is a pretty common occurrence. So in this particular study, they looked at 143 young cannabis users from 2 different metropolitan areas in the Pacific Northwest, where it is legal, to see to what extent that pain relief drives the use, like what percentage of those people are looking to improve their pain as opposed to just recreationally or for other conditions. So they recruited these people via social media. They hung up flyers everywhere, but not at medical establishments or medical marijuana dispensaries, though they did hang them up at regular marijuana like recreational marijuana dispensaries. So they, based on other studies they'd seen and baseline reports, they thought about 20% would probably meet criteria for chronic pain from prevalence estimates done elsewhere. They also thought that maybe pain relief might be an important motivation for all users, whether they did or did not have chronic pain officially. So their main inclusion criteria were 18 to 29 years old, so they were targeting a younger group, and weekly cannabis use at least. So at least once a week use. Of course, they had other things like had to speak English, and standard sort of inclusion criteria. It was an online survey, and participants got a $15 gift card for participation. So some of the questions that they used, they had a set of pain-related questions. So they asked about the current pain problem, and it had to be current for at least 3 months, again, to meet the definition of chronic pain. They asked about the frequency of bodily aches and pains during those past 3 months, the intensity of pain. They also had a body maps where you could click on various different parts of the body, and you can click on multiple areas too. So you can click on every part of the body that hurt, both a front image and a back image, so you can do the front separate from the back. They also looked at within day pain duration, like how long during the day do you have the pain, pain-related unpleasantness, how much does this bother you, and also disability related to pain. They also asked a lot of questions about cannabis use, including frequency, quantity, the types of administration, like did they smoke it, did they take it orally and edible, did they use a concentrate. Also, on the packaging in the Pacific Northwest, they actually label how much THC and CBD concentration is in that in the package that they get. So participants pretty much knew what they were getting, especially if they typically stuck with one kind, they would pretty much know what the concentrations were. They also asked them about the age at first regular use and then the number of years that they use this regularly. They also used some more standardized questionnaires, Rutgers Marijuana Problem Index, to look at negative consequences related to marijuana use. Also motives. They looked at how important different motives were. There was questions included about enhancement, like things to basically to get high to enhance their mood, social reasons, coping reasons, expansion, which is things like, to expand my awareness, and also routine use, where it was just kind of a habit, and so that's why they did it, just because they always do it. The authors of this study also added questions about pain relief as a motive as well. They found that the average age of participants in their sample was almost 24 years old. Most of them had near daily use, and typically via inhalation, and they preferred the high THC strains. Found that 40%, they were expecting 20%, but 40% met criteria for chronic pain. Half of those reported significant pain-related interference, so it was really interfering with their daily activities. The primary pain locations were musculoskeletal, migraine headache, and abdominal pain. And 95% of these participants who met criteria reported pain in multiple locations. The average was 4.5 distinct locations. So it wasn't just one pain that they were trying to treat. Interestingly, there was no difference based on gender, and the pain intensity they were reporting was it was in the moderate range. The average was almost about 5.7. Most of them, again, reported that they were at least somewhat distressed by the pain, and 50% had daily or near daily pain, usually several hours to all day long. So comparing the chronic pain patients with those who did not report, who didn't meet criteria for chronic pain, both of them did say that enhancement was a reason that they did use marijuana, but the ones that did not have chronic pain used it more for social, expansion, coping, conformity, routine motivations, pretty much all the rest of the motivations instead. The ones with chronic pain basically said that they did have, so they did use it more for pain relief, and they also used it many different methods instead of just primarily inhalation. They would use more like edibles or switch even sometimes between different methods. They used higher quantities though per episode. So each time that they used more than the non-chronic pain people. But there was no difference in frequency of use or potency. The chronic pain users also started weekly consumption earlier and used it regularly for longer, which is potentially of concern. And then they also reported fewer, but they reported fewer negative consequences. Although that difference was no longer significant when they took out gender and education and used those as covariates. So those with chronic pain typically used marijuana for pain relief was the motivation. So again, this could be important when you're developing approaches to reduce cannabis-related problems in young adults. maybe they need a different tactic. Instead of just saying just don't use it as much, maybe they need to replace some of that with some other support for other healthier alternatives for pain management. And chronic pain users were also higher in several factors associated with risk for problems. For example, starting regular use younger, which is also associated with a risk of dependence and cognitive deficits later in life. We're learning more and more that starting earlier has lasting effects. And then they're also more likely to use it alone than socially with other people. Chronic pain users did report fewer problems overall, but they still reported a high level of serious problems, including financial issues, interpersonal issues, work problems, tolerance, and dependence. So there's another study that was done about qualifying conditions of medical cannabis users. So basically, these are all patients with a license to use medical marijuana. And in order to get that license, a doctor has to say that they have a qualifying condition. So they used state registry data from 2018 from 20 states and Washington, D.C. that had available registry data. And then 15 of those states had patient-reported qualifying conditions available in the registry. So basically, the patients are saying what condition they're using it for. So over that period of time, in just 1 year, the registered patients went from 640,000 to 815,000 just in 1 year. Chronic pain was by far the most common patient-reported qualifying condition, 62% overall. In medical marijuana states, it was lower, it was 33%. And in non-medicalized state programs, 68% of people said they were using it for chronic pain. And again, this is just showing too, you can see the teal kind of line and stuff for chronic pain use for numbers over time. So the use started really increasing about 2008 or so, and now chronic pain is far and above higher. One of the reasons than anything else. The second one is multiple sclerosis, but that's way lower than chronic pain. So how effective is medical marijuana for chronic pain? The National Academies of Sciences in 2017 did a comprehensive review of the risks and potential benefits of cannabis and cannabinoids. They found pretty conclusive, or they were satisfied, conclusive or substantial evidence for improvement for chronic pain, nausea and vomiting from chemotherapy, and from spasticity from multiple sclerosis. But they basically said there's limited, insufficient, or no evidence so far for things that are allowed by different state laws. They didn't find it particularly useful, or the state of research is too immature at this point for PTSD, anxiety, cancer, epilepsy, and IBD. Which is interesting because now Epidiolex is FDA approved just recently for epilepsy, and it's a cannabinoid. So this is again just showing kind of the level of evidence. So at the bottom are the ones that have the most evidence. The conclusive evidence of efficacy, there's said, was for chemotherapy-induced nausea and vomiting, and then for substantial evidence, multiple sclerosis and chronic pain. So what about CBD? So what's the evidence for efficacy there for chronic pain? There's a couple of different types. Again, Epidiolex is recently FDA approved, primarily for seizures. And they're non-FDA approved products, but they vary widely in consistency and quality and what the THC content is. It should be less than 0.3%, but again, that kind of varies and it's difficult to really quantify. There is some decent evidence for the control of refractory seizures, some promising evidence for dosing right before anxiety-provoking events like public speaking, maybe instead of a beta blocker, take some CBD oil, and chronic use in schizophrenia. There's pretty weak evidence, though, for relief of pain and spasticity for CBD oil in their review. So they saw one small 12-participant open-label single-arm study of CBD oil in young girls, 12 to 24 years old. But they had a lot of psychiatric comorbidities as well, and chronic pain. It was kind of odd, from chronic pain from the HPV vaccine. They got sublingual CBD oil drops and supplemented by an additional dose. But they also, there were only 12 participants, 2 dropped out because of side effects, 2 stopped because it didn't help. So really, you can't really say anything about that small trial. But the ones who did stay in did say that they felt better, their body pain was better. There's another open label single arm trial of only 7 participants. They were kidney transplant patients actually, and they looked for pain relief in those patients. Again, the dose they used was 50 to 150 twice a day for 3 weeks. 2 had total pain improvement, 4 had a partial response, 1 had no change. But again, this small sample size, it's really difficult to really make any strong conclusions. There was one randomized double-blind multi-group crossover trial. So basically they had CBD, or they got THC, or they got CBD plus THC, or they got placebo for 2 weeks. And then they went to one of the other, there's a washout, and then they got one of the other groups. And then there's a washout, they did one of the other groups. So each person received all of these different conditions at different times. They had 24 patients with various different conditions, including multiple sclerosis, spinal cord, brachial plexus, lots of different things. But they said that CBD group did have significantly better pain control, but only 12 people completed the study. So adverse effects can include somnolence, GI issues, drug interactions, and it can increase your LFTs and suicidality. Kind of in the interest of time here, let's see, so basically the overall message is, do people use marijuana instead of different other prescription drugs? Yes, actually 69% substituted marijuana for prescription drugs in one study, and 84% was for a pain or mental health conditions. Also alcohol, tobacco, and illicit substances were other things that marijuana substituted for. Opioid medications were 35% of the prescription drug substitution, followed by antidepressants. 59% of the people who mentioned opioids specifically actually said that they stopped using opioids at all, completely. So it's possible that increased access to cannabis might wind up in reducing use of other potentially more harmful substances. And then there's just another one that basically came up with the same thing. 80% substitute cannabis for traditional pain medications, 53% for opioids, 22% for benzos. Next slide. And here's just kind of a list. 72% of the people who used it for substitution, 72% stopped opioids completely. Since starting the cannabis, 68% stopped benzos completely, 44% stopped NSAIDs, 74% stopped gabapentinoids. Interestingly, even DMARDs were stopped for a lot of them for rheumatoid arthritis, and only 3% said that increasing the medication, that they actually increased some of those medicines. So various cannabinoid compounds are used for the relief of chronic pain. It is a significant motivation for cannabis use for many people. There's reasonable evidence for chronic pain from medical marijuana, but pretty weak evidence for CBD compounds. And people who use medical cannabis might be using it to substitute for other medications, like benzos and opioids. It's unclear whether that's a good thing or not at this point. That's it. Thank you, everybody, for your attention.
We're at the end of our hour. Would you have time to field just a couple questions, or do you need to go?
No, I'm okay.
Oh, great. So any questions?
I have a quick question about the CBD inhibition of cytochrome P450 enzymes, and I don't know if you found any information about that in terms of safety and drug interactions.
No, they didn't really, the studies I looked at didn't really address that level of detail.
Yeah, please.
Yeah, I think I've seen something along those lines too. Nothing that actually developed into something clinically significant.
Maybe
and that
AEDs, but that's about it.
Yeah, where I haven't seen, reports of serious adverse events, but there is a theoretical.
Yeah,
right.
So I was just wondering, because we don't know how much it's interacting, how much is required before you get inhibition, depend on what level. So if it's with anti-epileptic medications, then you could monitor the dose, like the levels of those potentially, and see.
Yeah, right.
But
Yeah,
I
it'd be
haven't seen
interesting to
anything
use.
that to that level.
okay.
That'd be really interesting to get to the group if you. have
Yeah, I'll
something
look
handy.
at it again, but it was more
Okay.
just kind of these are potentially
Yeah.
the
Yeah.
stuff. Yeah.
One thing that was interesting to me in the first study you presented was a 40% rate of chronic pain in a group of people age 18 to 29. I mean, that seems to me to be a bit out of line with what I'd expect in the general population. And I wondered a little bit about the sample, but didn't know sort of your thoughts on that as a pain specialist.
Yeah, so they definitely said it was more than they expected too. As the study said, they thought 20% would be baseline in the population. So they were pretty surprised to get 40% too. I mean, you know, in my clinic personally, you would think that like everybody has, I mean, we see a lot of younger people, a lot of younger people where it's like, you know, they're like, oh, no, I have degenerative disc disease. And they're like 30. It's like, we basically all do after about 20 something. I mean, it's just an aging process and stuff. But yeah, I would wonder about the sample. Plus, you kind of wonder about reporting. Like, do they feel just more free to report it because they think it's a study about pain and stuff? Or they did try to minimize how much they focused on pain in the flyers and stuff. They put it just very in small print at the bottom and stuff. But it's possible if they happen to read the small print, they might say, oh, you know, this is supposed to be about pain. Maybe I should tell them about my pain.
Mm-hmm.
Well, and the criteria for being a chronic pain diagnosis seems pretty vague to me in general, right? I mean,
It was.
Right.
in the other indications that you listed, you've got nausea associated with chemotherapy, pretty objective, we can figure that out. Multiple sclerosis, we can diagnose that. Chronic pain, well, I don't think that quite fit that same level for me. So it always makes me wonder when they just say chronic pain. I don't know.
Hmm.
Okay.
No, definitely. It's a little hard, especially since it was just an online survey. It wasn't like they could do a physical exam or they could do anything, you know. You have to just take them at their report.
Great.